Today we hope it will be all right with everyone if we record the meeting. So a very warm welcome to this webinar today, and we're thrilled to see so many of you eager to join us. We actually have people joining from different places around, both new and old members in the network, students, people from Sudan, Bergen, Oslo, Trondheim, and so on. And before we start off, I just wanted to say a couple of network related things. The next newsletter will be sent out in the change of month, November, December, and information about the meetings for the next semester will be sent out soon. And now I give the word to Ragnhild Dybdahl.
Thank you very much, Ingeborg, and thank you all for joining the webinar. As Ingeborg said, we are very pleased to have a special meeting dedicated to Sudan. My name is Ragnhild Dybdahl. I'm the co-chair of the network together with Heidi Westborg-Stiel, who is also here. And many of us in the Norwegian network have strong links and warm hearts for Sudan. And well, therefore, it doesn't mean we don't care about other places, but we find that with so many ongoing crises, the situation in Sudan seems to be forgotten far too often. And because so many of us care and worry and have friends, we wanted to focus particularly on the situation in Sudan when it comes to mental health and psychosocial support. And we're really pleased, as Ingeborg said, that there is such interest in this topic, and also that we have such a strong panel with us for presentations today. We will first hear from Professor Shahla, whom some of us know from Ahfad University, but will also introduce herself. Then we will hear from Insherah Musa, who is the coordinator of the technical working group for mental health and psychosocial support. She's also a specialist in mental health psychosocial support in Sudan, I think currently based in Port Sudan. And after that, we will hear from Geir Løland, who will talk about one of the initiatives from the Norwegian side. And finally, but of course not least, we will hear from Dr. Unni, who will give us a short summary of her recent research work that has been carried out, at least partly in Sudan, and very relevant for the ongoing situation. After that, there will be hopefully some time for discussion and questions and comments. Whether the speakers want to take questions during their allocated minutes or not, I'll leave for them to decide. So again, a warm welcome, everyone, especially those who have agreed to speak to us today. And let me start by introducing and welcoming Professor Shahla Eltayeb, who is Assistant Vice President of the Scientific Research at Naif Arab University for Security Sciences, and also from the Ahfad Trauma Center in Sudan, and a renowned specialist on mental health and psychosocial support with enormous influence when it comes to the knowledge and the dissemination and practice of this knowledge in Sudan. Myself, I've been privileged to see Shahla in action over the years, and so I know what I'm talking about when I say you are a very important person, and we're so pleased that you can join. Shahla, up to you.
Thank you, Ragnhild, for the warm welcome, and I'm very privileged to join the network in this important platform. It is indeed a sad situation, and with heavy hearts that we are speaking about the situation of Sudan after a very hopeful era after the Sudanese movement in 2019, and that we are seeing this gloomy prospect of the war and the implication of the worst case scenario that none of us have imagined will happen. So I am going to be brief regarding, of course, the data and the magnitude, and I might share just a short presentation here regarding the current situation. Maybe other also colleague Insherah could shed more light on. I'm not sure if I'm able to share with the situation, but I'm merely going to focus on the close implication that hit psychosocial support and mental health workers in the field. As you know, the Ahfad Trauma Center in itself was established as a community-oriented service unit affiliated to Ahfad University, serving primarily the community of the university and the outskirts of Durman locality, which happens to be a large population. Also, we served a large community of internally displaced population and refugee community of South Sudanese in Durman, in Umbadda locality in particular. Since 2012, we have been providing free service to community workers. We entered into several collaboration and some support with project, for example, with the Norwegian Church Aid and with the Dutch Embassy and with the USA, in which we were able to train mental health workers, enter into collaboration also with Oslo University and Bergen University in conducting research and exchanging of faculty members and practitioners to support the work of the trauma center. Unfortunately, this has been now completely the premises of the university itself and the center is being fully occupied in the beginning of the war by the RSF troops and now by the military troops. So in both cases, the university and the trauma center premises are under occupation. We don't have access to further information towards the damage, but pictures surfacing indicates great damage that happened to the premises, and of course all our infrastructure internally, from computers, laptop works, and books and everything. Since the war in April 2024, over 3.8 million people have been internally displaced. This displacement, of course, put pressure on already poor resource setting. People have been moving towards poorer areas with very limited resources, infrastructure. We knew before the war that the number of psychiatrists and number of mental health workers were very few and primarily located in Khartoum state, in the capital city. We have big states in Sudan with no single psychiatrist serving. In Darfur, for example, in South Kordofan, we couldn't find any psychiatrist. That's before the war. After the war, even the scarce number of psychologists there have been forced to move. Who's doing what exactly is also a big problem, because the situation is rapidly deteriorating. We started to collect data, for example, after the hit in Khartoum, in Madani, in a Jazeera, and we started to some sort of trying to set up a service unit and a mechanism for referral pathways. Unfortunately, this has been also erupted. People have now moved from Al Jazeera, and Jazeera is witnessing large influx of movement, of displacement. The crisis hit hard those the most vulnerable, especially young children and adolescents. We have over 1 million university eligible students now outside the system. This not only lead to risk of large number of youth and young adults being displaced, but it makes them more vulnerable to be pulled into the to the military groups or war groups or other fundamentalist groups that we now witnessed entering the movement of Daesh and the movement of Shabab in Libya has made use of this vulnerable situation and lucid security status. So that's where they made a move and conquered some areas. We are very alarmed that this might be also the case in Sudan. We have seen in social media the rapid growth of hate speech, violence, and encouragement of violence, polarization of ethnicity, calling for severe racist and discriminating against the people. And this paves the way for usually organized crime to move in, and that's the case with the human trafficking of women being trafficked for sex and for other pure human trafficking that happens in Darfur. The numbers also were alarming in the case of nearly 60% of the displaced women have lost their income, their source. 1.5 million women and children forced to flee their houses since April 2023. We have the largest number of reported cases of sexual violence against women. So far, the reported cases are 2,000, which is a large number. We haven't seen this amount of number since the Darfur War in 2004. And which was classified as genocide and war crimes against humanity. We have seen now alarming number of reported cases, and of course the unreported cases will be by nature higher. There is a large connection between, of course, stigma, lack of reporting system, lack of valid process to document the cases. So therefore, we think the 2000 is definitely underreporting the actual scene in the case. There are several cases of also pregnancies as an outcome of this rape and delivery also of children. The Sudanese Gynecologists Association have reported several cases that were documented that as a result of the rape. We don't know the number of sexual transmitted diseases still yet. One of the sad situation with this current war is the lack of data and valid reports coming. Unfortunately, this is also being politicized since each party will try to divert the data, increase the number, and use it for their political agenda. And therefore, the cases is still very, there you will see fluctuation in the numbers and in the report of the consequence. Putting on my research hat, I think also conducting research in this situation is still very, very limited, very primitive, in the sense of not big research groups are jumping into or putting their efforts into documenting the cases, the stories, the narration of the survivors, whether on the border of Chad, Sudan, in Ethiopia, in the large number of refugees in Egypt or Uganda, even in South Sudan. You will see only a personal initiative from single researcher or a group of researchers, but still a big survey or assessment is not being undertaken. This gap of 1 year data will have its implication in the development of future intervention and programs. If you don't have the data, you will not be able to design well-informed interventions in the future. And therefore, this is actually a call for setting up research group that will document the current situation and put on a research program or research proposal that will capture the magnitude of what happened, similar to what happened in we saw fantastic research coming from the Ukraine war, from the situation in Bosnia. We are not seeing the same momentum. We do understand the context is different, the situation is different, but humanity is and the suffering is the same, if not even worse, in low resource setting and poor countries as in Sudan. However, shedding a light on a more positive note regarding initiatives that have been there, the movement from, and that's I think one of the double sword. The Sudanese by their nature are very collaborative, and they work and they jump into the rescue for each other, and that put a lot of burden onto the families and extended families, people working outside like myself in the Gulf area, for example. The strain has been quite huge to sustain the other family members who have lost their income, lost their houses, they are on refugee status. Still there are shy initiative worldwide on the support of the refugee situation in different countries. You will find primarily the source of income is coming from extended families outside or Sudanese in diaspora, which I think is masking the reality of the situation and the need for support. The other thing is that if I'm running more or late, you can stop me, is that initiative also for psychologists and psychosocial support have been relying on groups of psychiatrists and psychologists just donating their time, volunteering their help. In the Ahfad Trauma Center, we set from day one a helpline. So we try to maintain as much as possible the helpline and the telecounseling, because we had extensive training in setting up telecounseling before during the COVID. So it was just setting up the process again. However, it is also challenging because you are asking the psychologists themselves to continue donating their time and volunteering while they themselves need to secure some sort of income to sustain. So that's why we also initiated a call for helping the helpers, because the helpers themselves, they need helping. And if we continue depleting the resources, they will just burn out and shut down. And therefore also helping the helpers and just these community-based initiatives, community volunteers to be supported in a way that will sustain their services and to continue provide culturally appropriate psychosocial support and mental health. The situation with the referral pathways for refugees in countries like Uganda, Cairo, South Sudan is still very much relying on also personal initiatives and personal favors. We know a hospital that is willing to accept the refugees for free. The UNHCR has launched some programs, but the progress of the process is very difficult. Mental health services is in several countries is a tertiary level. It is a paid service, and it's a costly service. So people living with mental health disorders pre the war are struggling also to find their medication, to have access to the continued specialized mental health service. I know of a small initiative by psychiatrists in Cairo in which they found some sort of private clinic in which they avail free service for the community, which is quite a large community of refugees there. In a nutshell, or in summary, the situation is rather complicated. However, is there something to be done? Yes. The expertise are there, the will of the people is still there, the resilience of the Sudanese people is still there. We just need to capitalize on this aspect to structure the situation, because it seems this is a long war. It is not in the near future ending soon, and therefore waiting for it to end so as to intervene should not be the case. Thank you very much.
Thank you so much, Shahla. I know you could probably go on much longer as well, because you have so much knowledge, and we really would like to learn more. Hopefully there'll be time for some questions and discussion at the end. Thank you so much for sharing, and know that from the Norwegian network side, we admire what the Trauma Center and your colleagues from other places as well have continue to be doing. On what is being done, I'm very pleased to introduce to you Insherah Musa. We're very pleased you could take time out. Feel a little guilty for taking you away from your extremely important tasks, but so glad that you are able to join us. You're a specialist in mental health and psychosocial support, and you're currently chairing the technical working group, and we look forward to hearing from you.
Let me unmute myself, and please let me know if you are seeing my presentation.
Yes, but I'm not seeing it in presentation mode at the moment.
Now?
Still not, but
Still not?
I see it. No, but we can see it. So maybe we just go through it, because we don't have that much time, and I know you have very important things to share with us. Oh, yes. Now I lost it. So yeah, try again, please.
Yes, I want to retry it, and then we do things. Yeah, and so maybe now. So
I think you have to share your whole screen. Then you will be able to get it in presentation mode as well, because when you press presentation mode, we still just see the old
yes
version. So if you share your whole screen, it will, and then press presentation mode, we will still follow.
Tamam. It is not shared yet, right?
No, but if what you had, we could still see it. So it is not. It is not crucial. The crucial thing is that you're with us, and that you have very up-to-date information, and we are very keen to hear you.
So
just don't worry, we'll see it like this.
Okay, great. So I don't want to repeat what Dr. Shahla just mentioned. I know all of you know that the situation, unfortunately, the situation in Sudan is a bit complicated. It's not only the recent conflict and the recent crisis, and that the mental health is not currently is not a top priority comparing to the other emergency responses, especially regarding the pandemics, the cholera and malaria, and also the life-saving responses from organization. To meet the needs of a population around 50 million and a very huge country like Sudan, over than 2.5 million kilometers. It's not an easy thing. And to cover the states, the 18 states, and now I'm not sure if you can see this is the last updates from my colleague regarding security colleague regarding the IDPs and the movement of people, and where you see the blue circles, it's where are people moving, running away from the conflict in the middle, and then these are the locations that we are trying to serve. Some of them are, I mean, the MHPSS technical working group partners and the big UN agencies and the IO international NGOs trying to fill and to respond there, but some with some limitation in accessibility to some locations, especially Darfur, where we try to access and other organizations try to access through Chad and Libya rather than from Port Sudan or Kassala and Gadaref. And then the issue is also that the different localities, the different ethnicities in Sudan, and also now we have the IDPs, we have the refugees coming from Ethiopia and Eritrea before. And then the issue that even before the war, there were very, very limited mental health and psychosocial support in Sudan. And you could tell that in total, Sudan had around 60 psychiatrists for the 50 million population in Sudan. And currently, we have less than 20 psychiatry in Sudan that we are relying on for supporting the community. And the psychiatric hospitals are not functioning anymore. The 2 psychiatric hospitals that we used to have in Sudan, it's not functioning anymore. And what now, we used to also in Sudan to have, for example, 1 child psychiatry, and the child psychiatry that we used to have now in Gulf. The other thing that was a bit fine somehow is that Sudan has a mental health policy, and it was reviewed. Even the mental health strategic plan was reviewed in 2022, just before the war. And there were also adaptation of the mental health action work plan by Federal Ministry of Health that was endorsed by the Parliament in 2016. But even these policies and strategies need now to be reviewed and to be updated and adjusted to manage with the current situation and the huge gaps in mental health. Saying that, what we are trying in the technical working group to do is at least to activate the coordination, put our resources together, support each other in the different locations to provide a kind of respectful response with dignity to the community where we are working in different locations. So the National Technical Working Group was activated again in late July this year, and we have a bi-weekly meeting. Up to last week, we had around 6 meetings for the technical working group, and we started with 11 MHPSS actors joining us in the technical working group, and last meeting we had 33 active MHPSS actors joining us. In addition to the national level, we have technical working group at Kassala and Gadaref and also in Darfur. And mainly these states, because of the different weights of IDPs there and our accessibility to be there and to provide the services. What the technical working group started to do is to agree and to have a common understanding of our work, and that's why we developed in collaboration with the Federal Ministry of Health, mental health focal points. We developed an action plan for the technical working group, and the action plan mainly have 3 main components. It is the service provision, the response for mental health. The other component is capacity building. And the capacity building, we are referring to capacity building for the MHPSS service providers, staff, and also capacity building for other sectors, staff like health, education, GBV, that need also indirect contact with the community, and it's easier to access the community through them. And now, currently, last week we shared again the action plan with the partners to share their contribution to this action plan. So this action plan, it's not for the technical working group. I mean, we are as a technical working group not providing these services, rather than it is a collaboration and contributions from the partners themselves. We did a service mapping exercise just to know who's doing what and where and to whom. And we had that exercise in August, and tomorrow is the closing or the deadline to submit the new for the beliefs exercise, just also to see how things are changed since August, especially with the new influx of IDPs from Al Jazeera, and also the new services that we started to do in Darfur through other partners. So by tomorrow, we should have the analysis of the new service mapping exercise. Actually, one of one also of the big challenges that we were facing is the referral pathway. Organizations and the community, they don't know where the services provided and by whom. I mean, if you want to refer for specialized mental health services, you don't know whom provided these services, what's the contact details. And so we developed a referral pathway sheet, and it's supposed to be updated, covering 3 areas: the specialized services, the PSS activities, as well as protection, the GBV and child protection services. And it should be updated each month, and the technical working group at national level and the state level should, and anyone need the pathway referral, the referral pathway, they can have access to it. The other thing that was like recently in the last 2 weeks, we had an intensive meetings with different clusters, especially the protection, the GBV subcluster, as well as the child protection AOR. And the idea is that we put our resources together, we coordinate, and we support them in developing some materials with MHPSS lens in the wording, and how they can make it more sensitive to the community. I want to share with you some of the service mapping exercise results, but before that, I just want to highlight that when you know that the technical working group is under the health cluster, and then any organization who's providing MHPSS services, they are also reporting to the healthy cluster. And you can see that the indicators under the healthy cluster for mental health, which is if we are providing psychosocial support or a new mental health consultations, it is almost not there, not reported, or with the minimum reporting, if you can see the colors. And then the number of actors who's reporting to the healthy cluster as well is so limited comparing to the number of actors who's attending the technical working group at national and state level, and also who participated in our service mapping exercise. So in our service mapping exercise, you will see UN agencies, UNFPA, UNHCR, IOM, contributing to the service mapping exercise, as well as big INGOs like PUI, Save the Children, IMC, and Ahfad, other MSF, other local and Plan International, PU, World Vision. They are all part of the technical working group, and this is the mapping. And you could see also we have the partners are working in most of the accessible states, providing kind of MHPSS services there, trying to do that. And but still the other states that we don't have access to, or it's so complicated to reach there, or it's still with hot conflict that we can't be in person there, the services is still limited. But also you could see increase of number of beneficiaries reached and the majority of beneficiaries reach are female. Comparing to the male, and mainly people and organizations and actors focus on IDPs and refugees, and the majority also IDPs. Still, the host community is not taking a lot of attention, but I'm also concerned or wonder if we can say host community comparing to IDPs in context in Sudan where people are moving all the time and a lot of waves of displacement happened in Sudan. And for the service mapping, you could see that I mean the level of services, you could see that mainly level 2 and level 3 are taking the highest presentation on the services, while specialized services is still limited. And when we are talking about psychosocial support, the PSS activities, you could see also that awareness raising is the most activity provided by the actors in the field, while other activities is a bit limited. Still, there is some individual counseling and at level 3, as mentioned before, but specialized services, it's really limited in there. And then if we are talking about the number of psychologists and psychiatrists well-trained among organizations, you will always see, like, you know, one psychologist, one trained counselor, one trained on this training, and so it's really few numbers, and that's make the load on the service providers really high, with limited staff care and staff well-being for them in the services. And then these are the mandatory trainings that the staff usually take, and you can see, like, for example, PSEA is the best. The first mandatory training, then at least PFA is there, and also GBV basic trainings is there, and then other trainings provided by their organization. And then we asked the organizations in the service mapping exercise to identify what's the gaps in MHPSS within their organization, and the other question was, from their perspective, what's the gaps in MHPSS in Sudan in general. So they said within their organization, the gaps are limited human resources, that they don't have access to psychiatrists if they want to provide level 4 of services. They don't have psychiatrists who can do that. And also the limited funds for MHPSS comparing to other emergency responses, and also that they don't have resources in Arabic to prepare IEC materials, awareness raising, and how to do that. And then they don't have a specific human resource, I mean staff, that can monitoring the data, collecting the data, and analyzing the data, or document what's going on. And so organizations, they don't really have this component because of lack of resources, limited budgeting that they have, so things are not that documented. And also they mentioned that the organizations who have access in the inaccessible states, they have really limited resources and limited experience and quality of services there, which makes the service provision in such states are really not that efficient for the community in the states. And when we asked about the challenges in Sudan, again, the number of psychiatrists, clinical psychologists, specialized service providers are very, very limited and shortage. And also the stigma regarding the MHPSS, especially from male, the male and the community in Sudan, because when we refer to number of beneficiaries, the number of female is the majority of beneficiaries in the services provided. And also they mentioned that there is lack of technical support from the Ministry of Health, the mental health units, that they don't have resources, as I mentioned. They don't have, that you can't refer to them and consult if there is any technical need that your organization will have. And also the inadequate health facilities providing MHPSS there. So you will see later at WHO, we are trying to integrate the MHPSS within the primary healthcare and the secondary healthcare, which is still in progress and not really covering the needs on the ground. And then the weak referral system was raised again, and also the limited resource, the limited trainers in Arabic that they can train the local staff on the international guidelines like PFA, PM+, self-help plus there. And then the challenge to bring the psychotropic to the country. And also there is the other trend that psychotropic in other contexts, you know, psychosocial support and community-based intervention is the first thing, and then psychotropic is the last thing that we will go through. Here in Sudan is the opposite. Even for children and women, and the psychotropic is the first thing that the service providers will be providing. The lack of funds, and also even with the government response, MHPSS is not the top priority comparing, as I mentioned, to cholera, to malaria, to the other pandemics that, and the floods, and the life-saving shelter and security response that the country will have. For you know, as I'm wearing another hat as WHO program, MHPSS program specialist, the focus for WHO is mainly the capacity building, the MHPSS integration, the MHPSS service provision, monitoring and evaluation, as well as the MHPSS coordinating. And you can see that up to now, since the war started in April, that WHO, in collaboration with UNHCR and UNICEF, managed to train around 357 psychologists trained on PM+ and PFA. And these are the ones that WHO is using to integrate the MHPSS services in PHCs, in primary healthcare centers. And then to fill the gap of and the shortage of number of psychiatrists, the WHO also gave 280 doctors, mainly family medicine and general physicians, trained on MHGAP, and also the number of primary health care starting from June, that was had MHPSS component integrated, raised up to 23 out of 60 PHCs covered and funded by WHO for that. And also a new thing that we started to do is the mobile clinics, that the case management and the health mobile clinics, we integrated the MHPSS as a main component also in these mobile clinics, which make the reach to people is really high. So you could see that the number of individuals approach these clinics in less than 4 weeks reached to 1,031, which and the majority of them actually, for 94% is female for this, the same as the 3 clinics in Darfur. So the awareness raising was really essential to minimize the stigma and encourage the community to reach to the MHPSS services. And one of the a few steps forward for us as a technical working group and also as WHO is enhancing the participation in MHPSS technical working group, and also the contribution to the action plan. as well as the coordination with the other sectors to make it not only a response to what's going on in Al Jazeera and unfortunately what the sexual violence happened there, but also to keep it as a regular coordination between the health, the education, the GBV, and also the child protection clusters with the technical working group support. And also I'm communicating with the partners to see what's their plans regarding the capacity building for the first quarter of next year, to see how we can put these efforts together and how we can share the information with the other actors if they have access also to these training. And also to enhance, I was discussing with the healthy cluster, how we can give a training to the focal points of the MHPSS within the organizations to enhance their capacity to do the data collection, the reporting, keeping in mind the ethics in data collection and reporting when we're talking about confidentiality and privacy and informed consents for that. And also to focus, the focus for us is to build the institutional capacity, because this is the sustainability in enhancing the MHPSS services. And so to support Ministry of Health, to support the education, to support the institutions in Sudan, to be able to make sure that the quality of MHPSS services is really good, and to improve the data, the reporting, the research on this. That's all from my side. Sorry for the intense information. I'm stopping sharing and coming back to you.
Thank you so much, Insherah. Thank you so much for sharing. And I think you just exemplified what Dr. Shahla said about the resilience and the will and the commitment. And we realized that, you work under extremely difficult conditions, and it's so impressive to see, and a little concerning as well when you say you have 35 people or organizations at the last technical working group meeting and still only 15 reported in what they actually do in the assessment. So I'm sure you have a lot of challenges, but it's at the same time it's inspiring to hear of the work that's being done. And as you said, just in the 4 weeks, how many people have been reached by the mobile clinic, for example. So thank you so much for now, and I will introduce Geir next. Geir Løland, you have kindly and generously taken on the coordination of a volunteer initiative from the Norwegian side, and more of a solidarity act, actually. So please share what are your reflections on this. Thank you.
Thank you so much. I will try to share a PowerPoint with you as well to see if I can find it. Can you see this? Can you all see the PowerPoint?
Not yet, I'm afraid. No, here you come. Yep, wonderful.
Yeah, okay.
Yep.
The peer-to-peer meetings we have had, or support meetings, started up in September 2023, based on an initiative from Ragnhild Dybdahl in cooperation with Inas El-Hadi. She is a lecturer and counselor at Ahfad University. And this is supported by the Center of Crisis Psychology in Bergen. The aim for this was to create a safe place for dialogue, support, and exchange of experiences between colleagues. Basically, colleagues from Ahfad, but open to others who were invited by, and Inas is kind of coordinating this from Cairo, her place in Cairo. Initially, we were a network of 9 persons from Norway with different backgrounds, but all had experiences from Ahfad or other humanitarian settings. Since we started, we have had weekly meetings up till now this autumn. and we have had 1 hour each meeting. 2 from the Norwegian network group has been logged on in every meeting and is open to those who want to join us. So until now, we have had 38 meetings. At the most, there has been 13 to 14 people participating, including those from Norway. I think altogether, maybe up to 30, 40 people have been involved in the meetings. Some has just been on once, some have been there twice, some has been there just listening, observing, but many people have been involved actually. Basically, most of the people are in Egypt, but we also have people from Saudi Arabia, Uganda, Emirates, Turkey, South Sudan, and even from Sudan and the war zone. Those who have been in our meetings are in different situations. Most of them are outside Sudan, as I said, located in other countries, either with family, friends, or even alone. And some are in the war zone of Sudan. Some have been able to get out before, at the beginning of the conflict, some after, but in a safe way, and some have experienced dangerous escape. And this makes the situation for each and one very different, and it affects also our meetings. Before I go to, I will tell you more about the topics, but before I do, I wanted to say more about the people we have met in our meetings. I really have to point out and acknowledge and emphasize the admirable job our colleagues are doing despite their situation. We know that the feeling of actually helping make a difference can in many ways be a self-help, because it's meaningful to actually be able to do something. But being a refugee doesn't make this easy, and many were not able to bring documents or are not allowed to work during their stay and due to local authorities. Besides that, governments put restrictions on what they can do. And this is a difficulty all over, actually, but absolutely worse in some countries. Those who can, the work they've done, and those who can are allowed to, they work within different organizations in their country, helping others, doing therapy or counseling. Many of them work unofficially, meeting individuals or groups. For example, we have people who arrange for groups of children in parks or wherever it is possible. They do a huge online work that is actually whether they are in Turkey or wherever they are, they do a huge online service work, offering individually counseling, yes, some have actually done group counseling that are supported by organizations. They use social media a lot, producing videos about psychosocial first aid, self-care or specific topics. And they also do everyday support through meetings online or by phone. I also need to mention that staff from Ahfad University have done a great job trying to produce and provide documents to graduate students, and even been able to organize an internship for students in a local hospital in Cairo. So what has actually been the topics during our meetings? We haven't had any particular agenda. Dialogue has been about whatever is in the participants' concern. But however, there are some topics have been more present than other, and more recurring. I have, during all these meetings, produced 2 reports, and I've tried to summarize what I found that has been the topics. And the most recurrent topic is about self-care. Being in a situation where you use your knowledge to help others, facing other people's suffering, despair, trauma, when you more or less suffer yourself, easily lead to the feeling of being a helpless helper, symptoms of compassion fatigue, or secondary trauma. So almost every meeting have had moments of talking about self-care, the importance of putting your own oxygen mask before you help others. Other issues that has been topics is about daily life issues, like worries about family and friends, often families that are back in Sudan, or even families that are with them. It has been ordinary things like money issues, housing, visa issues, and also a lot about children, mental health, and youth. For example, they report about an increasing bullying of children and school discrimination, where teachers doesn't allow Sudanese students to take part in some types of activities in school because they are Sudanese and refugees. We also know that lack of hope among especially adolescents has led to some drug abuse and also symptoms of radicalization, which is really something the parents and the adults are worried about. We have also have moments where they talk about elderly people who suffer actually even if they are back in Sudan or even if they have been able to escape from Sudan. If they're back in Sudan, they suffer because they lack of medicine, basic things like food and water, and they don't want to leave their homes because that's where they live, is their homes, and they kind of demand family to be with them, which puts families into a very difficult situation. If they're able to get out of Sudan, they suffer maybe even more because they miss their homes a lot, and they have huge problems in adapting to a new place, new country, maybe even a new culture. We have also had in our meetings discussing mental health issues and topics like trauma symptoms, what to do, children and trauma, how to help children that are traumatized. We have been talking about depression, self-medication, mood disorder, isolation, LGBT issues, and about parenting in humanitarian settings. For example, single mother with children. PFA, anxiety, despair, and aggression. So more local or more mental health issues. We have also discussed cases when that has been a concern. When I was doing the reports and I was also preparing for this presentation, I remember a slide I got from Dr. Hannah Murray at Oxford Center for Anxiety Disorder and Trauma in England. And she, I think she illustrates very well in her slide how it is to be a refugee. When I was looking at this and writing this presentation, I found out that we have actually talk about most of these issues is also something that our colleagues both suffer from themselves and also meet in their meeting with other people. So what have we been doing in our meetings? Well, we have been focusing on being a colleague. We have been listening, encouraging, and acknowledge. And we have been, as we try to make it our meetings, like Ragnhild said in the beginning when we started this, having a coffee with colleagues at a table. So it's been more like being a colleague together. I think that's been actually very important. We have talked a lot about self-care, as I said, through sharing video links with our colleagues, sharing literature, stories, and articles. We have discussed cases and shared manuals like gender-based violence, for example, manual. We had more focusing on some topics like ICDP, TRT, and the importance of play and music, using play and music.
Sorry, Geir, we're running out of time. I don't want to rush you because I like to hear it, but just to make sure we have time for Unni's presentation. Sorry.
I'm very, very soon finished. Okay, and the Istanbul Protocol was also a topic at last meeting, and others related to mental health disorder. We had a workshop in Cairo, November last year, focusing on TRT, self-care theory and activities. And we have also been at TRT training online. So the feedback, which is my last PowerPoint, is that from our colleague is that this has been very helpful and supportive. They say it's a very good place for ventilation. One said, this helps me a lot. I used to be very concerned about how I would manage, but now I feel the support. Sometimes the meeting have led to further interaction also. When in one meeting we were kind of cut and they continued the meeting and just shared stories, experiences, sang together, playing guitar and singing, and really was supporting each other. Okay, I'll stop there. Thank you.
Thank you so much, Geir. Thank you for sharing. From all those, I think you said 38 sessions. It's incredible, and thank you for coordinating it. It really is very impressive how you've managed to do this week after week. Really, so grateful. And as you said, this is collegial support, and I'm glad to hear that the Sudanese colleagues appreciate it. But please also know that from our side, I think we appreciate it too, because it feels good to be in touch with colleagues, even if we feel a bit helpless when there's so much one wish to do. So thank you again, Geir. Now I have the pleasure of introducing Dr. Unni Hiltne, who will share her recent research, and we are very excited that you want to share this with us in the network as well, Unni. Please, the screen is yours.
Thank you so much, and also thank you so much for the preceding very interesting and meaningful presentations. I must really congratulate you on the effort of getting help out to in this very, very difficult situation, and also thank you, Geir, for the summary of the peer-to-peer support. Very interesting. So let me see. You don't see, do you see this full screen? You see it full screen? Wow, fantastic.
Yep.
I don't see it full screen, so that's why. So I'm going to talk to you about, actually this is my PhD project. And it's a project focusing on adult stakeholders' perceptions of how adverse experiences might affect children's mental health and the potential of school-based intervention to alleviate mental health suffering in Sudan and South Sudan. And this is a qualitative study. And the project the background for the project, of course, is that adverse experiences caused by war, conflict, and terror affect millions of children and are amongst the most potent risk factors for mental health problems, both for children and adults. And we also know that refugee children are especially at risk, and that parents and teachers can provide a key role in providing support, but they need to know how to do it, and they need to have the capacity to do it. And then the perceptions of parents and teachers and also other adults in the community, and also NGOs for that matter, their perceptions and understanding of children's adverse experiences and the consequences thereof is crucial. So, and also knowledge and how can we use low threshold intervention in local settings so that we reach out to the children who needs it. So the aim of this project has been to explore how adult stakeholders in Sudan and South Sudan perceive and understand refugee children's adverse experiences and the consequences, and also to explore stakeholders' views on the role of schools and teachers in psychosocial support and well-being for the children, and also to explore how experiences gained from using a low-threshold intervention called Teaching Recovery Techniques, TRT. Geir had talked a little bit about it already. The training in using the TRT, can the experience from that being used in also training other first-line providers in using this intervention? And can this intervention be an example for strategies that maybe teachers can be used in schools or other low-threshold settings? So the method has been a qualitative method where we had focus groups, interviews with teachers, parents, and local NGOs, and also some open questions at the questionnaire for the first part. And then I also analyzed field notes that was written from, I think, approximately 35 doing the TRT training for approximately 35 settings done over 20 years, and try to synthesize these experiences into some core questions that had to be addressed if we are going to use low threshold interventions and train specialists to use them. So these are just a very quick overview of the participants. There were over 60 altogether. There were a group of teachers from Eritrea living in Khartoum. There was a group of South Sudanese teachers living in exiles in Uganda. And there were also some fathers and also some local NGO participating in this study. And what we found was, of course, that the adults observed, the teachers and the parents especially, observed a wide array of potential traumatizing experiences. And of course, not surprisingly to everybody who knows the context and the horrible situation in Sudan, but still very interesting, because it's if we are going to build low threshold intervention in a local community, then we have to know what does the adults in that local community perceive, how do they understand traumatic experiences. So the observation of potential traumatic experiences related to war, of course, were many and very serious, as you can see, witnessing fatalities, witnessing people being injured, killed, witnessing destruction of infrastructure, experiencing heavy loss, hearing gunshot and shelling both during night and day. And these are just some examples of what were described. And also a wide array of what we call everyday stressors like poverty, hunger, child abuse, stigmatization of being refugees, and demanding cultural norms and expectations. And the consequences which the adults observed were also very serious, like children expressing a great deal of fear and insecurity, children expressing social withdrawal, anger, aggression, sadness, depression, and fear, lack of concentration, lack of motivation for school, hopelessness, and a lot of somatic symptoms, headaches, stomach aches, and frequent infections. Also, children dropping out of schools, children becoming addicted, especially children in refugee camps, to be able to cope with the horrible circumstances there, children becoming soldiers, and children becoming prostitutes. And the interplay between potential aversive experiences from the war and daily stressors like hunger and poverty and cultural norms, for example, attitudes towards girls, early marriages, school, and so on, the interplay between all these three factors had a particularly serious consequence. Now, there were a very clear recognition by the adults, both the teacher, the parents, and also the NGO, that there is a need to provide psychosocial support to children. And also an acknowledgement that schools and teachers could play an important supportive role. And there was a clear motivation to provide support, but a serious barriers to do so. So many of the teachers who were interviewed and also who answered the questionnaire expressed a sincere wish to be supportive to the children, but at the same time describe very serious barriers difficulties to do so. And the barriers were, among many others, a serious lack of resources, of course, both related to materials, staff, and knowledge. The traditional attitudes towards children, particularly girls, and education, poor management and lack of integration of information and knowledge of the consequences of adverse experiences from the school level up to the governmental level, lack of coordination between services and sectors, and lack of methods and routines to enable children and schools to support children. And then there was also this third paper, as I talked about in the introduction, where I looked about how could experiences from using this low-pressure intervention, teaching recovery techniques, can experiences from using that in many war-affected contexts be one example of strategies that could be implemented and also trained in schools, for example, or other professionals in the local communities. Now, TRT is a group intervention for children who have had traumatic experiences and who have developed trauma-related reactions to these experiences. And this intervention focuses on teaching children techniques on how to cope with these experiences. And when we went through all the notes from more than 20 years use of this intervention, and also looked about what have been discussed in the end of the trainings by the trainees of challenges, we come up with a group of core questions. For first of all, who could be recruited as trainees, like their age, and what should be the professional background? Do they need to be health professionals? No. Obviously not, but they need to have some kind of educational level, maybe a high school level, for example. What should the experiences be? We found that to be experienced interacting with children, for example, small children teachers stand out as excellent trainees using this intervention, and also their attitudes toward children and interaction with children. Then also, how do we train people who are not specialists and healthcare specialists to do this? What form and content should the training have? How could we structure it effectively so that we are able to teach this intervention in a short period of time? Because we have short time and we need to be efficient. How to support potential traumatized trainees. So when you are using this in a war-affected area, of course, the adults you are going to train will be traumatized, some of them at the same level as the children they are going to help. How to deal with this in the trainings, they will be activated by teaching these techniques. That is not necessarily a bad thing, but it has to be dealt with in a good way. Then also how to balance fidelity to the intervention method with the flexibility in adapting it to a special context, a special culture. How narrow do we have to follow the program? And how to address controversial themes in the trainings, like violence against children. While we know that being violent, for example, having a reputation as being a violent teacher, makes you quite unable to be a good group leaders for children in this setting. And also how to use the intervention in a responsible way, how to ensure children's safety and protect them from negative consequences of participation, and how to integrate this method with other interventions so that we do not create confusions and use resources in a non-efficient way. So the main conclusions from this study were that there's a wide spectrum of potential traumatic and severe negative daily stressors that affect children to a large degree in Sudan and South Sudan. And there is a cumulative effect of adverse experiences. Trauma and everyday stressors often intersect, creating a cumulative negative effect. And there is a need for a holistic approach and comprehensive interventions. And psychosocial support must be integrated with practical and material support. And effective teaching methods should be combined with methods to reduce trauma reaction. So we have schools. Most places have schools. Most places have teachers. In this study, we found that teachers were motivated to help children with adverse experiences. But of course, we need to verify this with a larger group of participation and so on. There is a need for the development and spreading of supportive child care practices. Was another main conclusion. And there are some areas for further research. You have already the excellent presentation that come before me already have presented. Shahla's presentation already also focused on the need to do research and to lift up the results to get the consequences of this horrific war to be known. And then I would think that exploring children's perspectives regarding what is happening to them and the consequences would be a very important focus point, even though it has a lot of ethical and methodological challenges connected with it. Then understanding adult stakeholders' knowledge and perceptions and perspective. This is just one study. We need to make a larger study looking into a larger sample of teachers and parents. And then identifying the need of resources, training and strategies to provide support and develop evidence-based child protection strategies to be integrated in the other interventions. Yeah, so that was what I had.
Thank you so much, Unni, for sharing with us, and congratulations on this important work. And I mean, it's so sad that it's so extremely relevant, but at the same time, good that you have provided such useful knowledge that will benefit people who will need it, and provides even more rationale to show that it's not just the psychologists who think that this is a way to do it. You've actually explored the perceptions of the communities and of parents and teachers themselves. So congratulations.
Thank you.
Thank you all for your very powerful presentations. It's quite moving to see both the enormous suffering and also the extreme efforts that are being made and the dedication that goes into this from so many partners. We don't have very much time, but there is have time for a couple of comments and maybe a question or two. If you're quick, then you can do it. We could turn off the recording, perhaps. Good